much, Bonnie, and welcome everyone this morning to our first session, which is Bridging the Gap Between Clinical and Community Providers. As Bonnie said, my name is Jean Clark, and I serve as CEO of Cascade Pacific Action Alliance, one of the 9 ACHs in Washington State. Cascade Pacific Action Alliance, or CPAA as we are well known as, serves a 7-county region in central western Washington, which includes Cowlitz, Grays Harbor, Lewis, Thurston, Mason, Pacific, and Wahkiakum counties. We also have the privilege to serve 7 tribes as well. We have a wonderful panel this morning made up of some providers across the state, but I'd like to take this opportunity to welcome you all to just sit back, relax, grab your favorite beverage if you may. I have mine here. Mine is grape juice. And really take the time this morning to pay attention and try not to multitask. I know that's really hard, but today's presentation will be worth your time. I'd like to introduce first Bridget Beachy. She is the Director of Behavioral Health at Community Health of Central Washington. This is an FQHC that is dedicated to the integration of behavioral health care services in primary care. Next, Dr. Mary Ann Woodruff is a general pediatrician in practice at Pediatrics Northwest, located in the South Puget Sound area. Thrilled to help lead behavioral health integration and transformation across the practice in partnership with Hope Sparks. She appreciates the power of stories to transform and is the medical director of Reach Out and Read Washington State. I also would like to introduce Eric Lawrence, who is currently a captain and paramedic with Clark County Fire and Rescue. He attended Spokane Community College to achieve an Associate of Science degree in paramedicine and also holds a Bachelor of Arts in Management Information Systems from Washington State University. Each of our panelists are going to share a brief overview of their work, and then we're going to move into some question and answers for about 20 minutes at the end. I also want to make sure that you are aware that Dr. Woodruff's colleagues, Wendy Pringle and Hope Sparks and Deanna Dudley, also with Pediatrics Northwest, are joining us today for the question and answer period. So with that, I'd like to turn it over to Dr. Beachy.
Hello. All right, good. You got the slides right up there, like clockwork. All right, so I'm Bridget Beachy. I'm a licensed psychologist by trade and Director of Behavioral Health, Community Health of Central Washington. We are a FQHC in Central Washington. We operate 5 primary care clinics. We have over 350 employees serving 30,000 patients, 3/4 of which have very low incomes. We have folks that are uninsured. We have ethnicities, a lot of Latinx population, and that are bilingual, Spanish speaking and English speaking. And we basically operate via the primary care behavioral health model. So in addition to some of my leadership roles, I actually am in the clinic about 40% of the time, operating as a behavioral health consultant, serving patients and our medical teams directly. And so essentially what we're trying to do with the primary care behavioral health model, also known as PCBH, is to fortify primary care. We want to increase access to behavioral mental health services. We want to reduce stigma. And at the end of the day, we want primary care to be the place that folks go. And we know that's where they go. And so we want to make sure that our nurses and our physicians and NPs and PAs are supported, because so many behavioral needs come through there. And today we're going to definitely, in the snapshot, talk a little bit about the growth we've had and the workflow that we have going on. And you could go to next slide. I was over there trying to click the next slide. And then you could click again, because I know it's on the, yep. So the philosophy that underpins primary care behavioral health is this idea that of the mnemonic of gather. It's this idea that just like primary care providers and physicians, we as behavioral health providers, we want to be generalists. We also want to be accessible. We want to be working with the team. We want to be highly productive. I know that that one is a little bit tough for some folks because when you hear productivity, sometimes people's brains go to the automatic association that it's about volume and not quality, or it's about money or something else. The way that we see it is the same way our primary care providers are very productive, which makes them accessible to their community, is the same way ourselves as behavioral health providers we want to be. So we're going to see on average 8, 9, 10, 11 patients per day if we're in clinic all day. We also take great pride in being an educator. This is where you get that interprofessional collaboration and interprofessional education. So it's really awesome to be able to work with the physicians and BHCs side by side in sharing of that information, as well as the nurses. And it's really cool to see how much that we learn from each other, essentially. And then also an educator to the patients, that to be able to come in on demand and get something done behavioral health wise, some type of skill or coping skill that a person can walk away with that day is really crucial to making, again, behavioral health accessible. And again, we want to be routine. We don't want to be down a different wing, outside into a different building. We see patients in exam rooms right where the medical team is. And oftentimes on warm handoffs, we're going to go right into the physician's exam room and see patients right there, because we want this to be a routine part of care. And we want to be able to serve all behavioral needs. And that's treatment adherence. That's just things that come up in life. Not everything needs to be a diagnosable condition. And you can hit the slide, it'll pull something else up. And then the last thing that I wanted to say with regards to our philosophy is that there's the 4 C's of primary care. If you're doing primary care well, you could be the first contact for your community. You're going to have continuity of care. You're going to have comprehensive care, and you're going to be able to coordinate care when possible. So being able to bring behavioral health consultants into the primary care mix can allow primary care do what it's supposed to do and support these 4 initiatives. Next slide. So I just wanted to give a really quick snapshot of the primary care provider's satisfaction to the behavioral health consultation services. So one of our biggest, I guess, clients, if you want to say it that way, is actually our medical providers and our medical team. If anybody here is a medical provider or an administrator, you know how much goes on and how much falls on your shoulders. So for BHCs to be able to provide support to our PCPs, it's of utmost importance. So we, every year since 2016, when we really beefed up our program, we've been essentially asking our medical providers, hey, how satisfied are you with these behavioral health services? How helpful are we to your patients? How helpful are we to you? Do we help your patients to kind of adhere to treatment plans? And do you, at the end of the day, do we make your job easier? And you can see on the far right hand side in 2020, that's the Likert scale of 1 to 5, with 5 being excellent. So we are on every category. In fact, it's interesting, if you look, we're at a 4.95 with how helpful we are to the medical provider. And I guess they said that we're even more helpful to them than we are to the patients at 4.8. I know it's not statistically significant, but I thought that was kind of fun. And then we have been able to go up from 3.7 to 4.0 with patients are more likely to adhere to their treatment plan. So I thought that that was another really big win. And you could go to the next slide. And then we'll go through this really quick, but a couple of qualitative responses. I know I'm running short on time already, but the ones I have highlighted are just some of the things that have been said directly by our PCPs. I've come to believe that this brings more value to the care I can offer patients than any other service in the clinic. This is the best innovation in primary care in my entire career. It is vital to good patient care. So once again, we want, as behavioral health consultants, to serve our physicians and support them on taking care of our community. Go to the next slide. And it's not just enough, obviously, to be really helpful to our PCPs. We want to make sure that we're helping out our patients. So they're involved in the survey that gets sent out that looks at provider listening, provider time spent, explanation of care. and our knowledge of their medical history and overall satisfaction with services. So if you compare our integrated program, where we're seeing folks for 25 to 30 minutes for the most part, there's some that go shorter and there's some that go longer, but for the most part, that's where we're falling. And to be getting out of 100 being the highest, routinely in the 90s for provider listening, provider time spent, explanation of care, knowledge of their history. People associate integrated with brief and then brief with superficial. We might be brief, but we ain't superficial. And that's not what this is about. This is about connecting with our patients. And we can go to the next slide. We have a list of qualitative statements from our satisfaction surveys, or actually, I think it's a patient engagement survey that goes out. I highlighted a couple. It was very heartfelt. BHC was really informed and organized. She gave me very personalized care. I like meeting with Dr. BHC. We've swapped out names, right? They listens to me, gives advice. They were able to understand me, makes it easy to talk to. This is what reduces stigma, especially for other cultures that maybe there's some fear around mental health. So to be able to go in on that same day, meet with a patient and have them to feel comfortable, heard, and to walk away with something, it's super awesome. Okay, next slide. This is just a graph of our team members of how much we've grown from 2014 and just keep going up and up because the demand from providers is so high, as well as administrators, as well as patients. You can go to the next slide. This shows our total encounters. I mean, since the time in 2016, we had this huge jump as we added BHCs to 2017, and the demand just continues to grow. And so we went from as little as 4,000 encounters in 2016 with our little team to now there's up to about 15 of us behavioral health consultants, and we're getting close to 13,000 encounters in a year. That's prorated for 2020. Next slide. This is our workflow. All staff and all providers know that BHCs are members of the interdisciplinary team. They know that we're generalists and we can serve all conditions, all ages, it doesn't matter. We have a board where it shows who is on in clinic at the beginning of every half day. If a warm handoff is needed, Microsoft Teams to BHCs who are out there, we respond within 3 minutes. We tell them what our ETA is going to be. We have both scheduled and then open for handoff, scheduled, and it's staggered all day long. And we try to be there to meet the demands of the patient and the provider in less than 15 minutes. And the BHC, we have this very short interaction with either a medical assistant or the medical provider. We get right into the exam room. We start seeing patients right then and there. And all of this scheduling is taken care of by the operations. Next slide. And just very quickly, this is what we do when we go into the room as a behavioral health consultant. I'm going to find out that patients love their work and their play. Who's in the home, what their relationships are like, what their spiritual and community life is like, what they're doing for income or work, what they do for fun, hobbies, passions, because that's what's going to make that connection. And then if we want to work on health behavior change or anything else that's going on, it's going to be rooted in the fact that I know this person. We also are able to figure out social determinants of health to get our care coordination team involved. We find out cultural aspects. This is where that individualized care really happens. Next slide. And I'm all good. I know that was super quick.
Bridget, thank you so much for sharing that with us. It's great work that's going on. We really appreciate hearing about it. We're going to go ahead and transition over to Dr. Woodruff now, so she can share some information about her program.
Thank you, Jean and Dr. Beachy. Our team is always eager to learn more about integration efforts across our state, and we draw inspiration from yours. First slide, please. We so appreciate the opportunity this morning to share our work. It's all about relationships and partnerships, which are at the heart of behavioral health integration between our two organizations, Pediatrics Northwest, a 25-person pediatric practice caring for 46,000 patients in the South Puget Sound, and Hope Sparks, full-service behavioral health agency in Pierce County, founded in 1895. In 2018, Hope Sparks and Pediatrics Northwest received a Catalyst grant from Elevate Health, the Pierce County Accountable Community of Health, in order to integrate behavioral health into the medical home, aptly named the Bridge of Hope. Presently, Elevate Health enrolled the Bridge of Hope team into the University of Washington AIM Center Pediatric Pilot for Behavioral Health Integration via the Collaborative Care Model, initially developed for chronic care concerns in adults. This investment by Elevate Health, both the 3-year runway of the grant and our enrollment into the AIM Center pilot, made our Bridge of Hope work possible. So began our partnership based on complementary missions of serving all, a shared vision, and a working relationship that we say is collective effervescence. Our aim from the start has been healthcare transformation to comprehensively address the needs of children from birth to young adulthood, to create a system that delivers integrated care, harnessing the power of prevention, emphasizing early identification, which is critical for nearly everything that I address in medicine, yet it's rarely employed for mental health concerns, and also provide early treatment. How? By creating patient and family-centered, community-connected, whole person care at the pediatric primary care medical home, and in so doing, addressing the goals of the quadruple aim. Next slide. This couldn't be more timely. 1 in 5 children and adolescents experiences a mental health disorder annually, and 80% do not receive treatment. Washington State ranks a sad 43rd in the United States for access to behavioral health care for youth. And less than half of the children referred for specialty behavioral health services actually see a therapist, and then many only see one once. And suicide remains the second leading cause of death for youth ages 10 to 24. Next slide, please. Let me tell you a story. At a family picnic, a 15-year-old had to lie down. His heart racing, he was sweaty, literally holding on to the grass for security. After some coaxing, he was eventually able to get into the car for the trip home. Subsequently, he couldn't take any car trips. Family excursions were canceled, and his mom took a leave of absence from work. The family met with me. The diagnosis of anxiety was made, and he was consented to our collaborative care work. He began regularly seeing the behavioral health care manager, with routine check-ins with me and psychiatric review sessions occurring as needed. At a recent appointment, he said to me, "I feel better, I feel happy, it's good." He's been able to start school. His mom is back to work, and they've resumed their family camping trips. Contrast this to the 26 phone calls on average that Washington parents must make in order to just make an appointment for counseling. Then there is the wait for the intake appointment, often weeks to months hence. In our collaborative care model, the onus is on us to connect to the family, not for them to make endless calls. This young man was better in about 12 weeks of therapy. In the referral method, his first appointment might not have been for 12 weeks, and he could have easily spiraled further and needed crisis care. Next, please. This is the how of our comprehensive care. We are taking a life course approach, a multidisciplinary approach to understanding the mental, physical, and social health of the children we serve. We use a public health lens, determining what strategies are universal and which are more targeted. What do families need for success? We have developed detailed workflows in these 3 categories: postnatal to 3, where we emphasize early relational health, the ability for parents to develop and sustain safe, secure, and nurturing relationships by routinely screening for perinatal mood disorders and infant development. We hone our surveillance skills with Reach Out and Read and promoting first relationships, and have developed deep connections to the early intervention system. From ages 4 to young adult, we utilize the collaborative care model with the goal of being able to successfully help 3/4 of the mental health concerns that we routinely see with our team at the medical home. And then, given that only 20% of what I do is strictly medical, we are implementing robust screening for the social determinants of health and developing feedback loop referrals in the community, starting with Help Me Grow Pierce County. Next, please. This is the backbone of our transition from episodic and crisis management to early identification of mental health concerns, the collaborative care model. We do universal mental health screening at all well child visits. Screening, for example, of a 6-year-old may reveal early symptoms of anxiousness, not yet meeting diagnostic criteria, but those symptoms can still be addressed before overt anxiety develops. The care is provided by a team located at the medical home. As the primary care pediatrician, I continue to routinely see the child and manage all medications. Our behavioral health care manager provides brief evidence-based interventions weekly, and the evidence-based treatments are from Seattle Children's based on cognitive behavioral therapy. And the pediatric psychiatric case reviewer consults with primary care and the behavioral health care managers, offering us expert advice. Next, please. We're all working at the top of our license, tracking engagement and progress using a registry managed by the care manager, such that if there's no progress in 4 to 6 weeks, the care is stepped up. So we started seeing patients on this model during the pandemic, and even so, we are realizing the promise of the Bridge of Hope. The initial appointment with the behavioral health care manager is happening within 10 calendar days of the consent to this care. And in this model, the phone calls are made by the behavioral health care manager to the family. Access is vastly increased, a necessary step to achieving equity. Next, please. Not only are children receiving services in a timely way, they are showing significant improvement. Over 70% of those enrolled in collaborative care for at least 6 weeks of therapy have shown improvement, and many of these are already in relapse prevention. And not one of our patients who has entered into collaborative care has been seen in the emergency department for a mental health concern. We are moving from crisis-oriented episodic care to a more upstream way to understand children and their mental health. Next, please. In our work, we like to say, we're providing the right resources at the right time, in real time for the families we serve. Our goal has been to develop this in a way that can be shared with others. If we do this necessary work, imagine the possibilities when we get this right. We can.
Dr. Woodruff, thank you so very much. I think I will never think of the number 26 in the same way as I have previously. That is a very powerful correlation between that number and how long it takes parents that are trying so desperately to get services for their children. Thank you so much. We're going to go ahead and transition over to Eric now, and he's going to share some information and some really good work that's being done in Clark County.
Thanks, Jean. Excuse me. So yeah, I'm just going to share about what work we're doing in Clark County with my organization, partnering with the Southwest Accountable Community of Health. And as it says there, the goal is improving access to quality care through using a community paramedicine model. And I know that's maybe not a common term for some people. So if we go to the next slide, we'll start talking about some of that. So community paramedicine, that term is also getting mixed in with mobile integrated healthcare. It's becoming a more, I guess, popular type of project for ambulance services and fire departments or fire districts like I'm a part of, to take on as a way to really help bridge the gap between what is happening in the pre-hospital setting and what's happening in the hospital, and then after the patient gets out of the hospital, and it can be done for a variety of reasons. But a lot of it is what we're finding is that the patients we're seeing aren't really a lot of times having a major medical issue. A lot of times it really has a lot more to do with their social situation. It could be a behavioral health situation, which we're seeing a lot more of now. And all those combine in with whatever chronic medical conditions they might have. And so we're trying to really just figure out a better way to deal with those situations in a more effective way, really. And honestly, paramedics and EMTs are not really trained to deal with major behavioral health crises. We get some training in a lot of different things. We're really generalists. And so we're trying to develop some more, really some more specialty people that can help deal with these situations. Essentially, all the different programs that are running across the country right now, it's like anything. If you've seen one EMS system, you've seen one EMS system. Every one is unique. Same thing with community paramedicine programs. They're all unique, and they are just ultimately just trying to fill a gap in the care continuum. Next slide, please. So a lot of these focus on different areas. Some of them do multiple things, but the examples here are a lot of it is focused on high system utilizers, whether that's we're seeing a particular patient call 911 multiple times, or if it's the emergency departments that have been seeing that patient multiple times. Maybe we haven't, but it's something that they can refer to the community paramedic to go and try and address whatever potential needs there are that is making them seek emergency care rather than maybe their primary care or trying to fulfill whatever need it is they have. Some of these programs are helping with hospice revocation and preventing people from revoking hospice. That's kind of a niche one. There's not a lot doing that. A lot of it, as I said, post-discharge follow-up. I know in our area, it's probably pretty common in a lot of areas. There is not enough home health providers to go around, and they could be up to 2 weeks before they can get out to see a patient, and that's assuming that they actually qualify for home health. So there's a big need there to be able to fill that gap that exists between when the patient is discharged and when they can actually get a visit from another provider. Readmission prevention has definitely become a bigger issue, which kind of ties in with the high system utilizers. Behavioral health crisis intervention, as I said, has also become a much bigger thing. And then a newer one, but is, I think, been proving incredibly effective, are what has been called, just a falls prevention program, is now evolving into, I guess it's a lot of places are calling it aging in place, but helping elderly folks to safely age in place. And that's actually proving to have some really good effects through not just cost savings, but also improvement in quality of life, and developing strategies to help families, whether that's multi-generational homes, or developing other ways in which elders can live more independently. Next slide, please. So about our program, so Clark County Fire and Rescue applied and received a 2-year grant. What we're doing with that is we've hired a social worker to be the program coordinator, because a social worker seemed like the right person to fill this role. As I said, a lot of the times it's more social determinants of health that we're dealing with, rather than strictly medical problems with folks that are continually accessing the system. However, we've also added a community resource paramedic. So that person's job is going to be working with the social worker, obviously, but primarily doing medical screenings, medication compliance, and things more on the medical side of things so that we can cover those bases. We also have a volunteer, hopefully, actually just recently, hopefully another one on top of the one already, that is going to be assisting with some of these things as an interest in social work. I believe the one is completing their master's in social work, and so they're looking to get some more experience in these types of programs. And so we're really excited to branch out as far as the fire department goes. We've traditionally, if you volunteer for the fire department, you have to, the only thing you do is you be a firefighter. Well, there's lots of ways that people can volunteer in their community, and we're trying to leverage some of those opportunities. So the goal with this program is, as I said, is really just providing outreach and follow-up services. Right now, our primary workflow is when our fire crews, EMTs or paramedics go out on a 911 call, they have screening criteria, and it's always left up to their discretion too. But essentially, if they identify any of the social needs, or a person maybe elderly that's at risk for a fall, has fallen multiple times, is identified maybe by family, sometimes is where we get a lot more information rather than from the patient themselves. They submit that information. That information gets sent to our social worker, and he is able to make further contact with that patient in the family, and be able to start addressing if they have some needs that possibly could be met in a different way. So all of the referrals, we're using Swatch's Health Connect hub, which is really becoming a pretty neat thing to have kind of a one-stop shop for accessing all of that client's information, as well as being able to accept and put out referrals to other organizations that we can partner with in our community. Next slide, please. So our project goals, again, we're trying to provide outreach. We're trying to work more closely with our health systems partners and our hospital partners. We're currently have just started doing referral process from Peace Health, which is one of our health system hospitals in our area. We're working at trying to develop that partnership with our other hospitals and health system partners. And ultimately the goal is just trying to, the IHI triple aim. I mean, it's heard over and over again, but it's really what we're all after. So it's, improving health, the patient experience, and trying to bring down costs. I think really what we're trying to do is just, like I said, fill a gap. We're not trying to compete with other services. The whole goal is if there's some niche that we can fill as trusted providers that are already in our community, then we want to try and do that. A lot of that is just the fact that we're already in the community. We're there. We're taking care of our citizens that we serve the best way we can, and we want to do better. And this is one way that we're trying to do that. Next slide. So just quick as an example, the falls prevention piece, the aging in place, like I said, has potential for huge impact, just because 10% of our medical calls that we respond to are related to falls, which is kind of shocking when you think about it. And so obviously some of those might not be hospitalized, but there's a fair number that go to the hospital and then subsequently may have suffered an injury for which they need rehab and may never return home again. Those costs start adding up very quickly. I did just very rough numbers. but I think anybody that is in the business knows that these costs of the emergency room, long-term care, rehab facilities, it's incredibly expensive. And so that cost, if we could avoid that, is really going to add up quickly. And obviously, we're just a small fire department. We're hoping to show some results. And then if we can replicate those in other areas, then it just starts getting exponentially bigger. And ultimately, it's not just about the money, right? It's about keeping people in their homes, having quality years of life added that they wouldn't otherwise. And so that's a really, really cool thing that we're trying to make happen. Next slide. So just as I was saying, this is trying to reduce financial burden, and improving quality of life. Those are really the things that we're after, and we're trying to do that, as I said, just by partnering with agencies that make sense, and hoping that we can, through the use of Swatch's care coordination system, as a kind of, like I said, that one-stop shop, we can bring all the data together and show some positive results for the patients that we're serving. And I think that's all the slides. Is that? Here, I'm trying to move slides. Next slide. I think that's it. Yeah. Thank you for the time.
Eric, thank you so very much for sharing about the community paramedicine program in Clark County. You guys are doing great work there. For those of you that are attending this session, if you haven't already, please feel free to submit questions in the Q&A box. You'll find it at the bottom of your screen. There are several questions that have came in, and we will do our best to get to all of them. But due to time, we may not be able to ask all of the questions. I do have a first question, though, for Dr. Beachy. Let's see here. Since integrating BHC into the medical team, what changes have you seen in medical providers' care with patients?
Yeah, I think there's been bidirectionally changes in care. Us as BHCs to be able to take into account more accurately what's going on with their medical side, because then we could just go right over to the physician and say, okay, what are we dealing with? What kind of functional impairment is going on here? And then the reverse is true with regards to the amount of conversations that we're having in the medical pod about ACEs. And that's like a regular term now. When I started working there, and I'm not saying it's all because of behavioral health, but when I started working there in 2014, nobody knew what ACEs were. Now every physician, I would hold that up to every physician in our organization. If I went up to them and said, patient has 3 or 4 ACEs, they're going to know exactly what I'm talking about. The amount of contextual information that they now bring to me on a warm handoff is unbelievable. They're bringing me the living situation, the relationship status, family, work. And I'm like, well, then what else is there for me to do? You already did the contextual interview. You already did that. And it sounded like you did a great job. So I think that that's been a major shift, is the focus away from symptomology and onto context, or not just symptomology, but really onto context, and then understanding social determinants of health, understanding adverse childhood experiences. So it's been really, really cool.
Thank you so much. We're going to shift gears here a little bit and ask Dr. Woodruff a question. Let me see here. Sorry, it just. Dr. Woodruff, have you had to tailor the collaborative care model to be most effective in the pediatric setting? And if you have, could you please elaborate a little bit on the changes you've had to make?
And yes, we have, and I'm going to turn this over to my colleague, Wendy Pringle, to answer that.
Thank you. Hi, I'm Wendy Pringle, and I'm the Director of pediatric healthcare integration for Hope Sparks and have just been delighted to work on this. It's just amazing work. And yes, we have had to make some changes as opposed to what the adult collaborative care model is. Specifically is we have changed the treatment modalities and really looked at brief targeted interventions that work for pediatric patients. We want to make sure that we're giving them the best possible treatment. We also have worked really hard to find screening tools that are very specific to the pediatric population. And we're constantly looking at new tools, making sure that what we're using to not only screen, but also track, because we track their progress and we also track the attendance at sessions. So we really use that registry and we know who's improving. We also know who's still having challenges. And so we want to make sure that we're using the very best tracking tools. And then in the pediatric model, greater family involvement is really a key aspect. In the adult model, the family context isn't quite as important, but we find that we spend as much time working with the family as we do the client. And that also involves working with other collaterals such as teachers, and even helping establish like 504 plans. And so it's really kind of looking at their greater world, I think, is one of the biggest differences. Thank you.
Thank you so much, Wendy. Eric, we have a question for you from the chat. Some of the audience would like to know, how long has your program been underway? And how many calls have you managed through this process?
So we've only really been under operation for probably just a couple of months now. We've had our kind of building the program from scratch here. Our social worker was hired several months before that, but just trying to develop kind of the policies and procedures we work under has taken some time. And now that we are accepting referrals, our fire crews have probably generated at least, even just in the first month or two, of at least 20 referrals probably from just patients they're seeing that they feel like could use some further follow-up with our social worker. And I believe right now he is currently seeing actively engaging with probably 6 to 8 clients, I believe, right now, and that number keeps going up. He is continuing to do follow-up and outreach with clients depending on their need. And some of them, I believe, there's been several that have been referred on through the Health Connect hub to other providers. Some that have been connected with services like housing, for instance, was one of our clients' needs. They needed their own place to be able to live independently, and now that need's been met, but then he's moved on to trying to help that client with some other needs. And so it's definitely an iterative process that it's not just see that person once and then we never see him again. There's definitely a lot more to it.
Thank you so much. This question is for all of the panelists. And my question is, what has been your biggest challenge? We've heard a lot about your successes, but what is your biggest challenge or maybe lesson learned? And Bridget, we'll start with you, please, Dr. Beachy. And then Marianne will have you go, and then Eric.
Yeah, there's been many mornings of rocking in the corner, just bewildered because of how difficult this work is to get traction. So I think that it's a marathon. I think that you have to have the passion and the resolution that this is going to happen, and have that vision and let everybody in your organization know what that vision is. I think that doing good BHC work is a really good start, because then you can get physician champions. And if we could get our physician champions, they can kind of move things along. So yeah, I would say the biggest obstacle is just that it's brand new. It goes completely counter to everything of the system, how it was set up. And it takes a long time it's just difficult.
And I will turn this first to Deanna Dudley, our Director of Operations at Pediatrics Northwest.
So with our program, we were collaborating with 2 organizations, and so that definitely was a tricky part of our program. And so it really was that we picked 2 organizations that definitely aligned with our goals and our missions. And so that was really critical with what we were trying to do. And our leadership teams worked really closely, and we spent many months designing our program and what we envisioned it to be. And so that foundation really led us to being really successful once we started. And despite getting going during the pandemic, we had the foundation really grounded, and the roots were really strong, so that we were able to not to let anything stop us. And we were ready to go and had the mission of taking care of our patients at the forefront of what we were doing. So I think that that really helped us be really strong, despite lots of trying times that we had.
And I would say the other thing that was a challenge but became an opportunity is within a 2-week period, we shifted to virtual, doing telehealth. So Hope Sparks is working entirely by telehealth. That is something that would have probably taken us a year to implement, and we did it very quickly, and we will never go back to not offering that. We see that as a really important equity issue as well.
So I'm glad to hear that I'm not the only one rocking in the corner. The challenges have been many for this kind of program. I refer to it as, am I the only one taking the crazy pills? Because I look at the numbers. That's where I guess my background is with data and numbers, and it just makes sense. We're trying to get upstream and prevent a lot of these costs and a lot of these problems. But the fact is, it's totally different than what the system was designed to do. EMS was never designed to integrate directly with the hospital. We've always been completely separate. We don't have access to the hospital's information. They don't have access to ours except when we hand a patient off, and that's usually with paper forms, which again is insane considering the day and age we're living in. And so there's just a lot of antiquated things, not least of all, which is the culture of EMS and especially the fire service. We are, 200 years of tradition unimpeded by progress. So, and I think there's a lot of other organizations and industries that probably are very similar. So we're really trying to flip some things on their head, and it's difficult because people are just resistant to change, for one. And then there was also some questions about in the Q&A about funding. We have no way of recouping any funding for this. We can't bill for these services because that doesn't exist within any billing code or billing infrastructure. And so that's something that we're really trying to figure out as far as from a sustainability standpoint. That's probably the number one thing, because obviously this is on a grant, which is great. That's what's got us going. But we really have to figure out, what does this look like for the future?
And I just wanted to say really quick that I want to give credit to the leadership at CHCW, our CEO who retired, but there was the beginnings of integrated care was latched on really strong at the C-suite level. And then we were able to go boots on the ground and then kind of merging those things together. I just want to give them credit that it wasn't like this is an all me or all a couple of the BHC effort. Just want to make that clear.
Thank you so much. The next question I want to pose to all of you is, what do you think your greatest success is? Just if you could narrow it down to one item, what has your biggest success been that you would like to share with the audience to empower them and help them to think bigger about what they're doing. We'll go ahead and start with you first, Eric.
Boy, that's, one success or one piece would be, I think it's just one piece at a time. Probably our most recent success was getting Peace Health, for instance, excited about engaging with us. Just getting a major hospital partner on board with this kind of program and to start thinking differently about things, I feel like was a huge win. And so I think just like a lot of these successes, maybe it's not the biggest one, but it might be the first one that starts kind of a chain reaction with others following.
Thank you. Dr. Beachy?
Yeah, I would say access and the fact that our penetration rate. So if you look at every patient, individual patient who came in for a medical appointment in a 12-month snapshot, right? And that's the denominator. Every single person who came in, medical appointment. Out of that grouping, how many of them had a BHC visit in a 12-month snapshot? We as an organization are over 20%. And at our mothership clinic, we're at 25%. So that means in 1 year, 1 in every 4 or 1 in every 5 patients has had a visit with the behavioral health consultant. So, and we are in rural Yakima. There's tons of stigma with regards to rural America, as well as different cultures and a lot of distrust, understandably so, with the healthcare system, especially mental health. And so we're able to achieve that because of how we present ourselves, because we're in the medical pods and we go right in 15 minutes or less in most cases.
Teamwork, teamwork, teamwork. I'm not out there by myself trying to do all of it. It's not possible to begin with. And all of us working together, the behavioral health care team and the medical team working side by side is incomprehensibly good. I think the second thing is that we ask, just like Dr. Beachy is saying, we ask families literally, how are you doing? And we don't leave it at just medical concerns. It's about it's really whole person care. And finally, our success really is attributed to having had Elevate Health give us that runway where we could look at this comprehensively and not just say, let's help the 16 and olders with depression and anxiety, but look at the very beginning at just what Dr. Beachy was talking about. Like, how do we look at families from the beginning and help support them? Because then we have a chance of preventing the downstream effect that we all know is out there. All the things that Eric is out there trying to deal with every day and has to do with his team, like by himself, we think that we can prevent it. And that's really the grace in all this.
Building off of that just a little bit, one of the questions that came in is asking if there's a formalized questionnaire used to track social determinants of health from any of your programs. Eric, would you like to start with that one, please? And then Dr. Beachy and then Dr. Woodruff.
Well, I wish I had our social worker here because he is incredibly knowledgeable about all that stuff. We have been building in standardized questionnaires into the care coordination system. And so off the top of my head, I cannot remember what that is exactly. Like I said, if he was here, he would be able to just rattle them off. But I'm pretty sure that all the things that we're using for screening are pretty standardized forms that are being used across both just from social work and behavioral health in general. I want to say is there a PCAM, and there's a lot more acronyms that I'm still trying to learn, which we have enough in our industry already.
Yeah, it looks like there's one from CMS. that was a 10-question item or 10 item questionnaire, accountable health communities, core health related social needs screening questions that I believe our care coordination team took that and made some type of iteration. I personally don't use it very much in my work. I use our contextual interview of the love work play, and then identify those social determinants, and then I send them to our care coordinating team, and then they oftentimes will do a formal screener. We also have had some piloting where every primary care patient who comes in to see their medical provider will be given that screener. They've done some pilots. And so I believe it's an iteration of the 10 items from CMS.
Jean, I'm so glad that this is being brought up, because our relationship with Elevate Health has led us to this, because we recognize that there is not a standardized one. And I'm going to have Deanna Dudley tell everyone about our efforts in this regard.
So we're working with Pierce County and through our work with Elevated Health and the Tacoma Pierce County Health Department, Dr. Woodruff and I are on a committee for this very reason. And we are trying to help Pierce County come up with a social determinant of health questionnaire that is actually for the pediatric population. And we are on the work group that has a goal of getting this rolled out by June. And with Elevated Health, there's some funding that's available to try to get a bidirectional data so that we can have our EMRs speak between each other. So in Pierce County, we have two large healthcare organizations that both use Epic, but they do not currently talk to each other. And so if we could get some bidirectional data exchange between them, it would help to get some population health data for our pediatric patients as well. So we are not only working on getting a standardized tool, but also trying to get that data in a way that could be utilized to better assess the needs of the pediatric patients within the county as well. So that is a goal that we have that the county is working on, and we hope to have that rolled out by mid-2021.
Fantastic. We're out of time, and I just really want to thank our entire panel for the conversation this morning and the question and answer. Thank you for sharing your programs. As a reminder to all of the audience, a recording of this session and copies of the slides will be available on the ACH website by the end of the week. And we're going to take about a 15-minute break before we come back to our next session, which is entitled Lessons Learned and Looking to the Future. And I would say everyone go refresh your drinks, and we'll see you in 15 minutes. Thank you so much.
Joe.